So, ladies and gentlemen, dear participants, welcome to this session on capacity development. And just in opening, I would like just to say that, as you all know, capacity development is the key, one of the key areas of EDCTP activities, as you saw from Michael Makanga's presentation the other day, that although the centerpiece is conduct of clinical research, but capacity building during conduct of clinical research is one of the major components of the program. And when I say the program, I talk about EDCTP1, EDCTP2, as well as now EDCTP3, and maybe it will be the same in EDCTP4 for those of you who will be there. And so it's great pleasure to see all of you, many faces that you have dedicated your service to building capacity on the African continent as well as in Europe, in many different capacities, that you are here today to hear from some of our presenters on how they have been able to contribute. And I hope this will open a debate of how we can do things better as we go forward. I think that should be part of the output from this gathering. It's not just about listening to what has happened, but learning from what has happened to shape the future. So I am Tom Nyirenda from the Africa office of EDCTP, and mainly engaging the African part of the EDCTP in this very important endeavor. And at the moment, straddling between two programs, EDCTP2 and EDCTP3. And in that respect, I also would like to introduce my co-moderator, who is from the EDCTP3 Brussels. Lydia, maybe you can introduce yourself.
Good morning, everyone. Welcome to this session. I'm Lydia Boudaren. I'm Senior Scientific Officer at EDCTP3. So we will have today a set of 6 presentations. We will have a short Q&A session after each presentation, and if time allows, we'll have an overall Q&A session in the end. We have many colleagues joining us online, so colleagues online, please feel free to share your questions. We will be monitoring them and taking them here as well. So it is my pleasure to present the first speaker, Professor Emily Webb from the London School of Hygiene and Tropical Medicine. Over to you.
Okay, morning everybody. So I'm very happy to be here today to present about ENTRANT, which stands for the Eastern and Southern African Consortium for Outbreak Epidemiology Training. And I'm presenting on behalf of my colleagues on the ENTRANT Steering Committee, who together represent the 7 partner institutions for the consortium, and all of our names are listed there. So firstly, a bit of background and context about how ENTRANT started. So a few years ago now, EDCTP, in collaboration with Africa CDC, launched a call specifically focused on developing capacity for outbreak and epidemic response in sub-Saharan Africa. And we were one of 10 consortia that were funded through this call. And together, all of our consortia are training 151 epidemiologists across the continent, and ENTRANT is training 15. And our aim is to educate and mentor high-caliber African epidemiologists working in the public health sector in 6 Eastern and Southern African countries, and thus to promote the development of a critical mass of epidemiologists to improve public health response. So we're a consortium of 7 partners, as shown here on the map. So we have Haramaya University in Ethiopia, the University of Nairobi in Kenya, Mwanza Intervention Trials Unit, or MITU, in Tanzania, Zambart in Zambia, National Health Laboratories in Botswana, MRC UVRI in Uganda, and LSHTM in the UK. And our three objectives are to establish a cohort of 15 epidemiology training fellows, or EPI fellows, from Eastern and Southern Africa, and then to provide our fellows with world-leading master's level training in epidemiology, and throughout the course of the fellowship to mentor our fellows to together produce a long-term mutually supporting network of epidemiologists working in public health in Africa. So this figure just shows how Entrant is organised and the large number of people involved. So myself and Kate Greenaway, who's sitting just here, are the coordinators, and then fundamental to the oversight of the project are the steering committee and the advisory committee. So our steering committee is made up of epidemiologists and public health scientists from each of the 7 institutional partners. And we meet every 3 months, and we use those meetings to really keep an eye and monitor the progress of how the fellowship scheme's going, and to troubleshoot any challenges that we come across. And we also have a really helpful advisory committee made up of experts in capacity strengthening initiatives who join our steering committee meetings frequently. And finally, we have a team of mentors who are drawn from the steering committee and from our institutional colleagues. So this slide is quite busy, so it just gives an overview of the key elements of Entrant and how we're organised. So we essentially have 3 kind of work streams. We have fellowship management in the middle, we have our training on the left, and we have our mentoring and networking activities on the right. And I think the main thing just to draw your attention to is that we recruited our epidemiology fellows in 2 cohorts. So our first cohort of fellows were recruited in 2021. And our second cohort of fellows were recruited in 2022, and they've just completed their MSc training. So just to say a bit more about what that training involves, so all of our fellows have taken a 1-year intensive masters in epidemiology at the London School of Hygiene and Tropical Medicine, and that includes doing core modules on the topics listed here, and also a set of optional modules which include various topics that are particularly relevant for pandemic and outbreak response, such as epidemiology of infectious diseases, mathematical modelling of infectious diseases. And they also do a 3-month project that is usually a data analysis and produce a 10,000-word report as part of that. The other formal training element that our fellows are yet to do is a short course on pandemic preparedness, which all of them will take early next year. So this is an online part-time short course, which is 1 day a week for 6 weeks. And it offers a focused perspective and approach to learning about pandemics. And as I said, that will be taken by all fellows early next year. So that's like a very quick overview of the programme. Now to say a bit more about how it's actually worked in practice. So our 15 fellows were recruited in 2 intakes, as I said, 8 in 2021 and 7 in 2022. And we recruited our fellows from a total of over 300 complete applications. And we actually interviewed, I'd think, about 50 people. And, you know, there were a lot of really excellent candidates that we couldn't, unfortunately, fund. But it just shows the sort of depth out there for this kind of training. Of our 15 fellows, we have 8 female and 7 male. And I'm really pleased that we managed to achieve that gender balance. And we gave quite a lot of thought to how to achieve this. So, for example, we made sure that our shortlisters and interviewers were gender balanced to help balance any unconscious biases. Also, since we were recruiting in 2 cohorts, our plan was that if we struggled to achieve gender balance in the first cohort, then we could put in place measures to ensure balance in the second cohort. But in the end, that wasn't needed. And we have 3 fellows from each of Kenya, Tanzania and Uganda, and 2 fellows from each of Botswana, Ethiopia and Zambia. And just to show our fellows, so our 2021 and fellows, we had 8, Many of them are sitting back there. And our 2022 fellows, we have 7. And again, many are sitting in this room. So one thing to highlight about the MSc is the research project. So this slide shows the titles for all 15 master's projects that our fellows did. I won't go through all of them in detail, but as you can see, there's a lot of variety in the topics studied. The original plan was that each fellow would do their project using data from their home country, and that they'd return home to work on that project in order to sort of further develop links with the partner institution in country. This didn't always happen in practice, usually because a suitable data set couldn't be identified. And unfortunately, the timelines that we have for our one-year MSc mean that it's not possible to do data collection as part of the summer project. Then just to say a bit about mentoring. So this is a really key part of the fellowship scheme, and I think something that, I'll say a bit more about this, something that we improved on as we went on through the programme. So we had a kind of triangular approach to mentoring, where each fellow was matched to a mentor from their home country, so usually the steering committee member from that country or a colleague, and they were also matched with a mentor from the London school. And the idea was that together those mentors would provide sort of general guidance, support, pastoral support, academic support, assistance with finding a good data set for the master's project, and then hosting the fellow during the project period with some additional funding to support that. We did have some challenges with mentoring for the 2021 cohort. And I think really the main challenge is that just some of those mentoring relationships never really got started. And I think it was sort of quite hard to pin down the reasons for this, but I think predominantly it was that people, their circumstances had changed since sort of signing up for becoming part of the mentoring scheme. And essentially they were just quite overburdened and didn't have as much time as they would have liked to give to it. But I think really essentially the problem was that, like us as a programme, I think we were quite naive because we didn't really set very structured guidelines or formal guidelines for mentoring. We instead rather left it to each triangle to figure out themselves how it would work, which I think on reflection was not the best plan. So for the next cohort of fellows and sort of for our original fellows over time, we developed a more structured approach. So we essentially worked together to develop mentoring guidelines, setting out what was expected from everyone involved in that relationship. We held a discussion and a training session that was facilitated by someone external to the project. And we did a lot more monitoring to keep an eye on how things were going and sort of intervene if needed. For networking and dissemination, so we've organised regular networking and information sharing events, grouping together our EPI fellows once both cohorts were on the go. So that's included things like social activities, meetings, sharing project plans and tips, sharing materials for grant writing and transferable skills training. We also have all of our fellows are part of a group called the International Statistics and Epidemiology Group, which is a group of, as it sounds, statisticians and epidemiologists who are based some in London but also around the globe. And that involves a mailing list and monthly meetings. And we also have a randomised coffee set up where people get randomised to be paired with someone else in the group and catch up either in person but more generally on Zoom. Obviously lots of our fellows are at this conference, which is great. We've been really happy that the EDCTP and us have been able to support them to attend. And one of the things that has been really good about the meeting is on Tuesday we had an Epi and Biostats Fellows meeting, which was really good and a really nice event. We also have funding for publication fees for fellows who are writing up their MSc projects. And we're in the process of planning a final dissemination event next year to share the work of the group. So to wrap up, as Tom mentioned, it's sort of good to think about what we can learn from, what was challenging, what was lacking, what could be improved upon. I mean, one thing was a bit out of our control, which was COVID-19. So for people who started in 2021, there was still quite a lot of disruption. So, for example, some of them had to hotel quarantine when they arrived in the UK. They also had to do quite a lot of learning online to start with, which I think created fewer networking opportunities. And I think that made it also just quite a tough experience. Secondly, as I mentioned, the plans we initially had for fellows to do their projects using data from their home country and as a placement at that partner institution didn't always work out, which, I mean, I think the key thing was that all the fellows did undertake a project that went well and were able to submit that project, but it wasn't as we'd initially planned. As it says here, mixed experiences of mentoring, which I think improved during the course of the fellowship scheme. I think it's so important to really, you know, start positively on that front and really sort of set out how you think, how things should work. A couple of things that were lacking, so something we would have liked to have included, budget permitting, was opportunities for postmasters placements. So, for example, to have placements where our fellows could like apply what they'd just been learning in their new roles. And something that we hear a lot from our fellows, and I think this came up a lot in the discussion on Tuesday, is that there's a lack of sort of progression to the next stage, so the next support with early career funding and PhD funding. To finish on what went well, so I think we have achieved our aim of having a networked cohort of talented and very skilled public health epidemiologists who, based on feedback, have found the learning to be highly relevant to their career plans. Most of the tutors and mentors have been very supportive, and also the steering and advisory committee members' expertise has been really invaluable. We've been really pleased that we've been able to provide opportunities for further training and conferences and publications. And we're also really pleased that we achieved gender balance, and that's actually not just for the fellows, but amongst the other components of the entrant team, which I think has been important. And then finally, I just wanted to highlight that several of our fellows have had babies during the course of the fellowship, which I know has given a lot to juggle and been quite challenging. And I hope that we've sort of tried, and I hope succeeded, to be as supportive and as flexible as possible. And I think that's an important part of a fellowship programme, is to allow that flexibility. Okay, so I'd just like to finish by acknowledging so many people who've been contributing to the project. So my steering committee colleagues, the advisory committee, our mentors and tutors, lots of other colleagues who gave up their time to help with shortlisting and interviewing, the EDCTP for their funding, and also particularly to Shingai and Niran for all their support throughout the process. And last but very much not least, the EPI fellows themselves. Okay, thank you.
Thank you very much, Prof. Webb. And just to say that EDCTP funded this joint program with the Africa CDC as not just because of the epidemic, but taking an advantage of that to bring the National Public Health Institutes closer to research, or bringing researchers within disease control programs. Because this is the biggest weakness we face in Africa, that research can be happening in its own world, this side, and then researchers, they are in these institutes, sometimes built with good intention by our colleagues from the north, and they don't speak to each other. And so this is a great skill that you are building epidemiologists that will be thinking about research and disease control at the same time. And I think based on that, maybe this can be done again, but the lessons you have put in your slides will be very, very helpful. So thanks very much. Let me open to two burning questions before we go to the next presentation. We'll have a chance at the end to bring you all the speakers at the front if there's extra time. Yeah, over to you, sir.
Right. Good morning. Thank you for the presentation. I'm Nobu from Nigeria. I just wanted to know, because in Nigeria we're having a situation where the highly trained and skilled field medical and epidemiologists we have are going out of the country to get better jobs. Your fellows, were they made to sign any agreement or anything to stay back and probably also develop others before going? Thank you.
Thanks for the question. Yeah, no, I think it's a really important point. So when people applied for the fellowship, they had to have a letter of support from their employer saying that there would be a role for them to come back to after the fellowship. What we have found that in practice is that's quite hard to kind of legally control, I suppose. What I would say, though, is that I think apart from a few fellows who are starting PhDs, all have returned, because that was also something they had to, we evaluated as part of the interview process, and sort of based on their personal plans. So, for example, we have people working in ministries of health, we have people who are sort of doing work with Africa CDC, we have people working in research institutions in their home countries. So I think it has worked, but it was quite hard to feel that we could sort of support that with the way we set this up. And I think some of the other consortia have probably been sort of like had a better job at that, actually, because the training was being done at home, so there wasn't this issue of moving away and having to move back.
Thank you. And there's a question here.
Thank you, Tom, and thank you for your talk. I'm a member of the African Research Excellence Fund peer review panel, and one of the challenges is building the research environment, the scholars that we train, and I want you to give us your thoughts about how to establish a research environment, research governance that enables these scholars to do their research and not to spend all the time running around doing the governance and the administration. Thank you.
Thank you for the question. So I think it needs investment at different levels and at different aspects of the research environment. So I think as well as investing in training people on sort of epidemiological skills, it needs investment in training the research management and research managers. And I think we worked with like the steering committee, all representing institutions where there's already like quite strong research management, so that people who work in there have less sort of that to do themselves. But I think, yeah, adding kind of more training in that aspect and building capacity of that aspect can sort of free up science time to do the research.
Thanks very much for that. Okay, Prof.
Yeah, thanks very much. Peter Smith, London School of Hygiene. I'm not sure whether this is really a question for Emily or a question for Tom. In terms of, and it relates to the last question really, is are there any plans for longer term support of these fellows once they've actually finished through this programme, actually going back into an environment that often they have to struggle to find a place? It seems to me that ECTCP may well have a role in terms of continuing to support this cohort of fellows.
Thanks very much, Prof, for that question. So I can take that on your behalf if you don't mind. Yeah, so as this is a joint program with the Africa CDC, we had a session where the representative from Africa CDC talked about how we can work together within their workforce development program at Africa CDC to make sure that we provide a conducive environment where the fellows are continuously engaged. And what we have done from the EDCTP side is to put all these fellows on the fellows alumni together with all the other fellows so that they can start to interact with the senior fellows and others. And we hope the senior fellows will also find that attractive, that they can tap onto the epidemiologists that have combined both field experience in epidemiology and also research. Yeah. And, but we'll be monitoring that, and I think continuous input is what is required so that we can achieve what we want in the Africa continent. Is that answer your question? Yeah, thank you very much. Thanks. Let's give a big hand to Prof. Webb. So the next presentation is on bridging the research gaps in AMR in Sub-Saharan Africa within the concept of One Health by Ria Kobiaka. Over to you.
Yeah, many thanks for the introduction. Dear ladies and gentlemen, I'm happy to present the ADAPT project to you. The ADAPT project is a One Health approach to bridge the research gaps on antimicrobial resistance in Sub-Saharan Africa. Antimicrobial resistance, or short AMR, has become a predominantly problem in worldwide. The problem here is, like, if you have a look at this graphic here, the deaths in 2019, we can see that there were more deaths linked to AMR than they were to HIV or malaria. The reasons for this is mostly the overuse or misuse of antimicrobials in veterinarian and human medicine. Especially in Sub-Saharan Africa, the region with the highest burden of AMR worldwide, there is the need for improved surveillance and antimicrobial stewardship. The mission of this project is to build the capacity across 7 Sub-Saharan African countries for the improved management of AMR and neglected tropical diseases, and for the improved stewardship of antimicrobials. The focus here lies on a One Health approach and the strong collaboration with state, local, and regional stakeholders. To show you a bit the diversity of this network, we are working together with institutions of 7 Sub-Saharan African countries, including Sudan, Ethiopia, Uganda, DRC, Nigeria, Ghana, and Senegal. And we are working together with the BFR in Germany, which is the reference laboratory of AMR. Okay, so it is a huge project. I'm trying to include you as good as I can. So first of all, we've got the overall project management and coordination at the Makerere University in Uganda. And the research package is divided into 6 different tasks. So first of all, and most importantly, we've got the screening of AMR. The screening is done in each country separately, but it's coordinated by the Institut Pasteur de Dakar in Senegal. First of all, we are screening we are doing the public health surveillance here, but in a second part, we are also developing a smartphone application to collect all the data and to make it accessible for as many people as possible. In the second task, we are going to investigate the relationships between AMR and neglected tropical disease infections. This is mainly done in Nigeria. And then we've got, at a third task, the development of point-of-need diagnostics, which are suitable to identify AMR directly at the point of need. In the fourth task, we are investigating the impact of the COVID-19 pandemic on the use of antimicrobials and the development of antimicrobial resistance. In the fifth task, we identify the hygienic practices which are different in each institution, and we are going to improve the protocols and share it with everyone from the project. The task 6 is AMR stewardship, and this one includes all the data and the knowledge we gathered from the tasks before, and this is mainly the spreading of the knowledge. All of the tasks together are leading to a capacity building of course, of the leadership of in antimicrobial stewardship, the data and financial management, the AMR surveillance and diagnostics, and most importantly, the training of young researchers. Another part of the network is the networking. So it's really, really important to work together with policymakers, local authorities, and healthcare workers, as well as international and local organizations. And last but not least, we have the engagement and the transfer of knowledge. So we are developing SUPs and guidelines, which are published each year, and we do workshops and seminars. And we are present on many social media platforms to share the knowledge with a wide range of people. And of course, we are planning to have open access publications. So coming to the research package layout, as I said, we are doing this in a One Health approach. So we are including not only animals or only humans, we are including animals, the environment, and humans. So, for example, in the animal side, we are collecting samples from chicken and livestock. We are sampling animal products like meat, milk, or eggs. And for the environment screening, we are screening the wastewater as well as drinking water. And then, of course, we've got the human sides where we are going to test stool samples and from hospitals and from healthy communities. The collaboration with the local networks, so far we are collaborating with the African Forum for Research and Education in Health and the African One Health University Network. And they mainly assist with the delivery and dissemination of the AMR stewardship training programs. On the international side, the ADAPT project does align with the One Health Joint Plan of Action of the United Nations. And here we also really focus on the 4 Cs, the communication, the collaboration, coordination, and of course the capacity building. Another thing the project does address are 7 of the 17 Sustainable Development Goals. With the effective hygiene measurements which will be developed, we improve the animal production and we improve the AMR surveillance and diagnostics for a better health and well-being. Another thing we are addressing is the equality, education, and gender equality, as we are training young researchers, for example, masters, PhDs, and postdocs, and we're really happy that we've got equal amount of girls and boys there. With the rapid screening of the drinking water, we assure or contribute to assure the delivery of clean water. And innovative diagnostics are going to be developed and validated to make sure that they can be used at the local point of need. We are a really multidisciplinary One Health network because we are working together with a lot of different institutions, not only veterinarians and human medicines, but pharmacists and epidemiologists in the different countries. The project impact is, first of all, of course, the capacity building for the AMR surveillance. But like I said, it's also really, really important to include the policymakers and the local authorities to make sure that the project is sustainable. And last but not least, it is really, really important to train the young researchers. In each local facility, we do train at least 1 or 2 PhD, master, and postdoc students. And all of the institutions are really working closely together. So we also have the funds for collaboration and traveling, as well as some meetings where we all can be together. And And yeah, with this, I would really like to thank my partners. Here you can see the task leaders in a meeting in Cape Town. And if you're interested in this project, I would be really happy if you join our newsletter on our website, because this project just started this year. So it's ongoing for 5 more years, and we are always happy to collaborate, to share our knowledge and protocols which we are developing. And yeah, now I thank you really much for your attention, and I'm looking forward to your questions.
Thank you very much, Dr. Kolbeke, and I think it's very important to have this multidisciplinarity put forward as you have presented. Let me open the floor for questions. We'll start there and we'll come back here.
Hi, I'm Magda Conway. I specialise in youth engagement in global clinical trials and research. Really interested in this work. I think it's absolutely critical. So first of all, congratulations. I suppose my question to you is there anything within this? You talked about using social media. Is there anything around this where you're looking to share with the population? Because obviously we need people to understand AMR. We need people to respond as well as researchers. And also, as I said, my specialism is around children and young people. Anything specifically that you're thinking about doing to share this information with them as well?
Yeah, that's a really important point. So we try to really include as many people as possible with, for example, we realized that in a lot of African countries, social media is quite important. So that's why we included it. We are on Facebook, on Twitter, on LinkedIn. With this development of the smartphone app, we want to make it accessible for everyone, so it won't cost anything. It just can be downloaded, and there we want to spread the knowledge for as many people as possible. Yeah, but we are always looking for innovative ideas there as well.
Can I? Okay, thank you very much for that exciting presentation. So I just have one question, at least following some field experience we have been having. I think it's interesting to see the One Health approach and the different areas that you are targeting, in particular that of antimicrobial resistance. So one of the areas that I don't see you address in your presentation is that of environmental toxicity, that particularly resulting from use of herbicides and other chemicals to spray farms for agricultural outputs, and that exposes particularly livestock to risks of toxicity. We have been seeing a growing the incidence of that, particularly in Cameroon and Nigeria, and that also has an impact on human health, because we have been seeing an increase, an increased level of liver toxicity in humans, and also renal toxicity following ingestion of some of those animals that have been killed by toxic chemicals from the agricultural sector. So I think these are some of the emerging areas that we see, and we are still struggling to study them. But I think it would be important if you think about them from a broader perspective on really what can be done to actually incorporate this type of or capture and study this type of determinants in the One Health approach. Thank you.
Yeah, that's a really, really important point. We are mainly focusing here on the foodborne pathogens, so those which are transmitted mostly by animals to humans. So mostly like salmonella, multi-resistant pathogens. And but yeah, of course, this is a really, really important thing we should have in mind.
Thank you very much. We have one last question at the back.
Yes, thank you very much. I would like to congratulate the team on this important work. There's one area where I feel you also need to do something. I did hear that you're going to have a policymakers forum, something like that. Mm-hmm. But I think in that policy platform, you really need to look into what is so different in the African context to the point that we're getting what we're getting right now. And I think the prescription practices, there's also enforcing regulatory controls. We know we have the TMDA, we have all those, but I think at a policy level, we need to come up with very strong message because you'll have an opportunity to talk with the gatekeepers of this. So I think that is also a nice component, and if it's a global network of this nature, that is only where we can safely address that and, make changes. Thank you.
Yeah, you're really right. That's like kind of the most important part, to have it sustainable and not to just have it work during this time, because we want to have all the protocols included for a longer time and to really improve the surveillance there. So that's a really important point. Thank you.
Thank you very much. I see there was another burning question.
Thank you for your excellent presentation. I implemented a program like this in Liberia for about 2.5 years, and I just wanted to share my experience. We need to do that. Most of these African countries, almost all the countries you are in, I'm sure they have their national action plan against AMR. And I just want to emphasize the importance of incorporating what you are doing into that system. So most of the countries have technical working groups on AMR based in the Ministry of Health. And it was very helpful for us to integrate from the beginning, so that our resistant data was fed into the national data. So I just want to emphasize again that you have to, for your participants in those countries, to be part of the technical working group and let them have the information that you are generating. Thank you very much.
Thank you. That's really important.
Thank you. And one last question on the left.
Thank you very much. Very nice talk. My name is Abdullah Jimde. I'm actually want to ask you whether, in terms of dissemination of the results, whether you are thinking of involving social science tests to reach out to the communities in addition to your students and staff. And the next is that you probably, I don't know whether you know it or not, but we have an African Association of Research and Control of AMR that has membership in about 26 countries. We hold Congress every 2 years. So if we can reach out and see how your network can be represented in that forum and of disseminating AMR-related activities. And the last is to add we just, through this association and through our initiative, we just launched an AMR, a master's degree in AMR, registered at the University of Science and Technologies in Bamako. It's just starting now. So first students will start in January. Courses will be taught in English. So it's open to applications for those who want to have a degree in AMR, where we want to cover the whole spectrum of AMR, not just one specific area. Over.
Yeah, those are great news. And just let me think. The collaboration with the AMR Association in Africa would be great. So I would love to connect with you there, because, like I said, we are still in the beginning of this project, and so far we've got collaboration with those local networks there, but we would love to spread it more, to be connected there. Thank you.
Thank you very much, and great to see that new collaboration are being established today. We can give a round of applause to Dr. Kolbaka. Thank you very much. And it is my pleasure to introduce our next speaker, Professor Trudy Lang, who will present the 1,000 Global Research Studies Challenge.
Thank you very much. Good morning, everyone. Good morning, everyone online as well, or good afternoon, whatever time of day it is. Let's try and move these slides on. Do we need to have the next set of slides up? Do I need to do anything for that? Great to see such a full room. And just whilst they're putting my slides up, I just want to thank EDCTP for this meeting and for enabling us all to be here. Our work began completely because of EDCTP and our work with the Networks of Excellence, and the projects that came from above and beyond that. And I think these meetings are absolutely unique, and we all value being together in person. And I think the reflection is the mixture of young and more mature people like ourselves, Tom. And just thank you, and thank you for letting us present this. Hopefully, I've ad-libbed enough. Can I have my slides, please?
Which one are you?
Do you know who I am? Hi, Tom. We've only known each other since we were children.
I still need my glasses to
That's
to
a bit-
recognize you.
Thank you. So I hope this is a bit different. I'm really excited to present this project to you. It's a huge collaborative effort between lots of organisations, and it's just beginning. We're literally launching it in Africa, in Nairobi, at the end of this month. So my talk now is a plea for all of you to get involved. Take it back to your centres. And what I'm going to explain, hopefully, the idea of this is to be a really pragmatic way to enact capacity development. You know, I know so many of you in the room, we've all dedicated our careers to research, capacity building, and for the youngsters here, this is maybe an opportunity to really get some of this underway. This is about flipping the pyramid. I want somebody to do a PhD called Flipping the Pyramid as well, because I think this is something we could measure a lot more than my graphic here. A lot of the research that we all do, and we've all been involved with, and we all know the statistics about, 10% of research in the world only benefits a very few percent, 90% still happens in the global north, and of the research that happens in Africa and other low resource nations, so much of it's still led from elsewhere. We talked this morning about how it hasn't even been designed and the question set by the local needs or policymakers. And a lot of the research at the top of this pyramid, and I think COVID was a great example. We had 500 odd trials asking the wrong questions, in the wrong people, in the wrong place, and billions wasted. Of course, all sorts of research is vital, but I think we're missing out on a huge opportunity of doing a lot more research, pragmatic research, probably in primary care settings, run by nurses, field workers, community health workers, asking pragmatic questions to exactly the same standards as every other sort of research, but delivering immediately applicable outcomes. And so this is about flipping the pyramid, so the base, the strength in where healthcare delivery happens, especially in many of the countries we all work, where most of the care is delivered by nurses, field workers, pharmacists, looking at the whole ecosystem of where research happens. So the 1,000 Challenge is a programme that we're just about to launch as a partnership. And we're really taking this on as part of our work as a WHO collaborating centre. And that has come about because the science division at the WHO have this mission of what they call research everywhere. And Soumya Samanathan, the previous head of the science division, used to talk about research being measuring what's in front of you. And that's research, and often we get tied up in research being highly complex, expensive, grant-driven trials. So this is about looking at it from the base of the pyramid, where the strength is. So we're delivering this through the Global Health Network. I hope lots of you are very familiar with this work. It's a huge global partnership now. It's the Global Health Network is the community that use it and contribute. It's made up of research organisations, sponsors, funders, research teams and networks that use the Global Health Network to disseminate and work with their teams. And it's also the community of people that come in their thousands and thousands to access the tools and resources. It's all about equity and where research happens and who leads and who benefits. So the idea of this 1,000 Challenge is literally enacting that. It's just a very straightforward mechanism that I'd love to get your feedback on as well as we're beginning to really set it out, of just trying to change some of these inequities and give a really practical framework for it to happen. So this is around trying to think about those frontline healthcare workers, most people that see patients every day, and in many of the care settings, it is nurses, it's midwives, it's community health workers, it could be pharmacists. Hey, AMR, thank you, that was brilliant. And we really want to work with you with the AMR Hub in the platform as well. It's a great example. And we've been talking about working on AMR as a really great topic within this, with lots of the organisations that we're beginning to talk to this about this, particularly AMREF, I don't think there's anybody from AMREF here, because we're launching this at the AMREF conference at the end of the month. And they're doing a lot of work on AMR and doing some really straightforward data capture on antibiotic use with Africa CDC and trying to enact some of the stewardship studies. And so this is a great topic. You know, most antibiotics are delivered, used, you know, they overlap with One Health. This is a great example for doing some of this connecting up. So where could research happen where it's not so much at the moment? In these settings and led by these people. But the real reason we've built this around the work we're doing with WHO, and I'll come back to Sustainable Development Goals right at the end, is a leadership opportunity. And also what we've learned as the barriers to research, which I'll come on to in a second. But if these frontline healthcare workers are going to become research leaders and develop their own careers and have a visibility and a voice and franchise, you know, we know healthcare structures are often quite hierarchical. It's true across the globe. So how do we give these core workers a voice, a mechanism for being seen and being heard, and a framework to develop their careers? And so we've really built this around a leadership and career development opportunity, but it happens also to be a really powerful way to enact many of the things we've talked about. I really liked on both the talks we've just heard around the importance of workplace training, and you know, and your new master's course in Africa for AMR is excellent. It's keeping people in the workplace and in their home countries, and making sure that the skills and the training and development can happen in situ. So this is all about workplace training and giving access to tools and resources and qualifications. I'll make a blatant shout out as well. We have a diploma for global health research that is entirely online. It took me 7 years to persuade Oxford to do an entirely online qualification, and it's the first of its kind. So the cohort of students can remain in their workplace and do it part-time. This is a leadership opportunity to train people how to do research and give them long-term and sustainable research skills. So what is it? So the basic idea is that anybody working in healthcare delivery in the lab, in a pharmacy, midwives, nurses, in the community, in primary care, it could also be on the ward as well. I'm going to give an example later. They should think about, what could I change right today in my practice? What do I know? It's instinctive. These practitioners know that they've got a particular problem in this group of patients they see. What could I measure and assess or test that could change that there and then in that setting? So then it's taking them through the process. Okay, what do you need to measure to understand that? And then what do you need to test? And then how would you do that? How would you collect that data? How would you give that intervention? And what would you ask? What was the outcome that you'd measure to show that was different? So you can see I'm already breaking down all the sometimes really complicated descriptions we have of what research is. And you'll see the whole system we've built. It's really breaking down those steps of how to do a research study really well. What is your question? How will you measure what you're going to ask? How will you capture that data? How will you then analyse it and turn it into a recommendation? And then, of course, what we talked about this morning, how do you take that recommendation into policy and practice? And the point is with this system, every single step of the way, the teams will be given the opportunity to say, I have no idea. I'm absolutely stuck. I don't know how to do this step. And so in that instance, they'll be guided to find help, and that could be in terms of people. We're going to have a whole, and you can all volunteer. There's an area on the hub where we want experts to come forward. It's like sort of immediate mentorship. We talked this morning about the protocol development tool. This is crowd support for doing these studies. So these guys might set up the study and they might get stuck on how to set up REDCap or how to do community engagement. We want them to be able to access a whole volunteers, army of volunteers out in the crowd to help them. So you can register and say, yeah, I'll help. My area of expertise is data management or community engagement or outcome measures. And you just might get connected. We're going to do a bit of a sort of dating site bit in it, so that they can access the help. But we'll also pinpoint them to resources, topic particular or around areas like data management. So every one of those stars will be a point where they can access the help that they need. So let me give you a couple of examples. I went back to my home turf, the Can We Welcome programme in Kilifi, and I talked to the nurses there and said, is this a crazy idea? And they said, oh, we've done some kidogo audits for my, kidogo, many Swahili speakers in the room, small, kidogo audit. And I said, well, tell me. Oh, well, we had these children, we had 500 children a year on the ward with burns, 60% mortality, and they thought we can change this. So these nurses in their kidogo audit set up their own data capture form. They went back into all the hospital records. They extracted the data for the last 5 years on burns, and then they looked at what were the interventions with those burn kids. Bandaging, different sorts of bandaging. And of course, they were found that the deaths were caused from sepsis. So they did their data capture, they set their questions, they looked at what happened to these children and that one form of bandaging had a way better outcome than the other. So, of course, they changed to the better form of bandaging, measured that, and guess what? The mortality went down from 60% to about 20%. That's not a kidogo audit. That is an amazing piece of research. And I said, how come that was under the, why did you do it quietly? Oh, we were just doing a small audit. And isn't that the story with nurses and health workers? And they work in one of the best research centres in Africa. And they were quietly doing this. And they did another one about neonatal outcomes, the same thing. And there's going to be a video of Mamvua on the platform about why it was quiet and under the radar. And it's because nurses don't have a voice, and they don't feel, even in the centre like that they could step up and do this work. So another group of nurses in Nepal, I had the pleasure to meet 6 months ago or so, and we sat and did a workshop on this same thing. And we said, right, what would you like to do? What would you do? And they're doing some work with the WHO on mental health outcomes. And they really said they're doing all of these programs across rural districts of Nepal, where they're looking at really high suicide rate in teenage mental health issues in Nepal. Probably, obviously globally endemic. But all these nice initiatives, they're setting up support groups, clubs, lots of these interventions. We don't know if it works. Perfect. This is a perfect one to put through here. How are you going to find out if it works or not? What can you do? And then could you look at villages where you haven't put these systems in yet and start measuring? So we just workshopped how to do that. And of course, it was really straightforward. They would be a perfect 1,000 challenge study. A quick piece of background information on this. We work with the Global Health Network community a lot to ask questions about what makes research difficult and what the barriers are to research. This is pooled data from 2 studies we've done recently, one with the World Health Organization on the World Health Assembly Trials Directive. You might have heard if you attended Vass's talk yesterday, and another piece of work with Wellcome on setting funding priorities around infection. In both studies, we said, what are the barriers to research? All of this, what we're talking about today. And so this is completely, raw, unpublished data. But it's really interesting just to show how completely that we pulled the data. It's exactly the same story. And it's exactly the same across the regions. And all of you who've worked in this for years, you know the answers to this, right? But it's good to see it down in evidence. And these are, research skills training. This is what we're all trying to do. For this particular challenge, there's a really important barrier that this helps to overcome, and this is institutional support from research. And I was staggered but delighted this came out second. For these nurses, for Mamvua in Kilifi, for the ladies in Nepal, actually stepping up and saying, I want to do research is the hardest step. Is going to their managers on their ward and saying, I could be a researcher, I could be a PI, and coming together as a team. So this 1,000 Challenge project is about them being able to come together as a small team, registering their study, and then us helping them go back to their whoever they need to and say, I want to do this research. And this is a really important, I hope, benefit that this programme will deliver. Funding. Everybody says, who's funding this? These are supposed to be really strong return on investment. These are not big studies that need a grant. I know, amazing. But this is the point. This is about the institutional support. It's about spotting questions that can make an immediate change in the workplace, and that the buy-in needs to come actually from their institution, and they help them get it through ethics, and they help them have the time to do it, and that overcomes that last piece. So the system will take them through all of those steps and help them along the way. And what we really want is some groups to come forward. You know, you all work with people, juniors in your centres, who there's either some studies they might have done already we could slot in, great to have some exemplars for others like the Kenya studies, or build these ones, and we'll help them to it coming through. So it's a call out to all of you to get involved. And workplace learning, working together, collaborations, really want different organisations to get involved in this, and some groups like AMREF, CEPI, others are going to take it on as their own and have the AMREF 1000 challenge, and you know, we can have the AMR 1000 challenges. And so I throw it over to you to just join in. We haven't got any funding for this, by the way. Oh, any funders in the room? We haven't got any funding for this. We're just doing it because it's the right thing to do, and it acts as a really good framework for a lot of things that we've all been talking about. So that's that. Over to you all for questions, and thank you very much for the chance to show it to you.
Thanks
here.
very much, Trudy. We all appreciate your passion in this and years of dedication. And just to connect the dots, some of you may not have been part of this discussion, but in this forum, the Department of Science and Innovation from South Africa brought in the discussion they are having with NIH and the Medical Research Council of South Africa, and it's exactly what you're saying about certification of researchers, starting from the gate man at our research center, the nurse, up to the top, and the professor. And bear in mind that most of the professors don't even have a GCP certificate. I put
We
my
can
head on
change
the
that,
block
Tom.
there. But this is the reality on the ground. And if we are going to unify training of research, we need to look at the whole continuum. And thanks for your work. I think because of time, we'll
I
take
do have
just
a question,
one
sorry.
burning question, yes,
Thank you
before
very
we go
much.
to the next.
So thank you so much, and thank you for raising this as a nurse, having been inspired to be a nurse because of being born and being raised in Africa. Just one thing that I do a lot of clinical research, I do this, and I really appreciate you putting that. I also sit on the International Association for Research Nurses, and there's two things that I just want to say. I'm missing one word, which is evidence-based practice. And I think one thing is to do research, the other thing is to talk about what we did in some of the sessions this morning and to say, well, how do you get that great research out on the field? Because at the end of the day, it's that bridge between the science and the bedside. That's very important. My other point is that the reality is that, you know, compared to the US or Europe, etc., and even in Europe, we have a lot of diversity between what is actually a nurse and how they are trained and so forth. The reality is that in the fields, where we're working in neglected diseases, where I am at the moment, is that the nurse actually, when there's no doctors, the nurses are the doctors, and they have very different needs, and they're very important. So the question is how we support and finance that is extremely important, and I'm glad you raised that. So in the current context where I work, where I see nurses, the ones that actually come and are able to, even by the time that they raise their hands to do research, is because they're in great centers, etc. So I want to know how we're going to reach the ones that are in the villages actually working with the patients, you know, on the malaria projects, for example. And I want to know how we're going to reach the non-English speakers. Parce que quand on travaille en RDC, when we work in our DRC, for example, you know, which is one of the highest population, we talked about high populations, you know, growing populations, pediatric, etc. There's at the moment not enough in the languages to be able to reach those populations.
Thank you. Great. I'll take those in reverse. The whole thing's going to be translated French, Spanish, English, Portuguese. It's absolutely implicit in everything we do. Second is about reaching everybody. The entire absolute target audience is frontline allied health workers in primary care settings, and we're going to be working with many organisations such as AMREF who deliver projects in those settings. But Karibu Sana, please help us. I mean, that's the point. And we've got a really strong global network that can. That's the point really of enacting them there. And also you're right about the roles. You know, there's clinical officers. There's more and more effort on community health workers. So, yeah. Absolutely, and that evidence-based mention is exactly that gap it's trying to connect. So thank you, all beautiful points, and please work with us on this.
Thank you. Yeah, thanks very much. I'm Val here from one of the UK funders, NIHR. And just to build on the comment, thank you so much, Trudy, really interesting. Just to build on the comment earlier, I really like this idea of kind of mainstreaming research into people's jobs. And if anyone from TDR is here, they have a lot of experience also in doing that with the Sort It programme. So the idea of research becoming part of people's day jobs through these projects, Trudy, if that's the idea, I think that sounds brilliant. My only comment was in the pipeline. What I would love to see is for your burns example, for example, there's a lot of research now on how do you with the best treatment for wounds and burns, and recognising that your colleagues didn't maybe have access to that research evidence. Going back to the evidence-based comment, is how will this, what I didn't see is in your pathway, which I'm sure you've built in, is how does that then link to the world of research evidence, so that those nurses through this project can immediately do what they probably feel they can't do at the moment, which is to see, for example, all the NIHR Burns funded research around low and middle income countries, which has now been invested in, for the last 5 years or whatever. So that's one question. And the second thing actually is for Tom, who's standing next to me, because also, Trudy and Tom as well, is that EDCTP now has this great alumni platform, which has been showcased here. And many of you here will probably be on that, because I guess the reason we're here is EDCTP. And so what I'd also love to see is, can this type of platform link automatically in to things like the EDCTP alumni platform and others, so we don't have a plethora of different platforms people need to go to, but people here who are on one platform can immediately link in a seamless way without having to have a new login and know that the Global Health Network exists, etc. So I guess those are my 2 points. Thanks, Tom.
Thanks, Val. And while Tom warms up, yes, exactly. So Sort It, we're working really closely with them on this. It's a great idea, and this is the focus on this project and learning from them. Connecting up, absolutely. The whole point is signposting through the steps. So question 1 will be what exists already, and helping that we always try and, it's equity and access to knowledge. So it will be trying to point information to them they didn't know exist already. So what is the evidence base already on burns? And then at the end, that last piece around evidence into practice we talked about this morning. And I think what the Global Health Network does incredibly well, if it does anything, is the connect and convene. And so connecting up and in many different ways, including that opportunity for people to register themselves as experts. And we'll be haranguing all the networks to put their teams forward and that for them is another way of an outcome from their expertise they've gained, and they can keep contributing, is to sign up, and they can also cite that they're doing that to show that their own training has worked. So absolutely, connecting it all up.
Thanks very much. And from the EDCTP side, what I'll say is very well taken, your comments, Val. And we used to be worried when this Brexit thing was going on and on. We are happy to have UK back in this. So we will use the UK manifest to implement what you are recommending here. So thanks very much for those comments. And let's give a hand to Trudy. So our next presenter, the video is not here, so we have an opportunity to go straight into the presentation from Professor Abdullahi Jimde, who is going to talk about clinical trial capacity from scratch, the 1CAM2 experience in Niamey. Where's the escape? Is that the way?
Yes. You lost your glasses? Or what?
No. I think my French is disappearing. Over to you, Prof.
Thank you very much. Thank you, everybody. I'm going to actually give a follow-up talk of my my talk this morning on broader capacity building by sharing our experience on how we are building capacity in Niger. And this is part of our EDCTP2 funded program, WANECAM2, West African Network for Clinical Trials of Antimalarial Drugs. And a lot have been said about South-South collaboration. Most of the collaboration is North-South, and we are trying to promote South-South collaboration. And in doing so, we are actually doing it in a manner that we build capacity around us, starting with our neighboring countries, so that we can have collaborators with whom we can effectively work. So it's in that spirit that I presented the work that we did in Guinea earlier this morning, and now with WANECAM2 we are doing pretty much the same thing in Niger. So it's as the other networks, it is an Africa and Europe consortium where we are collaborating with Novartis and MMV to develop a new non-artemisinin-based combination therapy, the Caflum, a combination. And we are trying to improve clinical studies capacity in the West African sub-region. We started by identifying a novel team that in Niger, where if you look at the research output, there's not much happening in terms of biomedical research. So the aim, I'm focusing on the capacity building, which is part of our work package 4, led by Prof. Jean Bosco Ouedraogo from Burkina Faso, who has not made it to this meeting. And the Niger team did not make it to the meeting either, for non-scientific reasons, as many of you know. Yeah. So the aim is to build capacity and capability in the development for the conduct of ICH GCP compliant clinical trial from the ground up. We wanted to provide GCP training to the team in Niger, transfer technology and maintain GCP compliant clinical trial capacity, help them to initiate, design and implement in vivo efficacy study that's learning while you do type of approach, where we are starting with a randomized trial with drugs that have already been approved, but whose result is fed to the national malaria control program. Ultimately, to bring the team to a level where they are going to contribute to the phase 3 Kaluma trial, the Caflum trial, that drug non-artemisinin-based ACT combination therapy that we're working with. We started by a fact-finding mission first to assess what is on the ground, and then we nested a clinical study, like I said, a prospective efficacy study comparing artemether lumefantrine and artesunate pyronidine, which were both both ACTs that were registered in Niger. The study was a randomized study where we compared artemisinin and artesunate pyronidine and artemether lumefantrine, included patients randomized between the two arms, and gave the first 3-day treatment and followed them for 42 days. All of this done in Niger with this nation team. So as we train them, they learn on the job. So the first thing was, since we are doing clinical trial, we need to start with GCP training, good clinical practice training. That's the prerequisite. My friend was saying that some professors don't have GCP certificate. If you do clinical trial, you would have to have that. So we started by bringing a few leading members, senior members of the team to Bamako, in Mali to attend our regular GCP training. Every year we offer GCP training in Mali for new staff or for staff that certificate has expired. So we brought three senior members to attend that workshop, and then we took the Malian GCP trainers to Niger to have to train the rest of the rest of the team. As you can see, this is the workshop that we did in Niger with some of the Malian trainers who spend a week there to train the rest of the team so that we can have everybody certified before we start the clinical trial. So this is the infrastructure development part of the exercise. During the site visit, the first site visit that we did with our Novartis and MMV colleagues, it was in April. It was very hot, 48 degrees in Niamey that day, and we were touring the city in a bus that had no air conditioning. So I'm sure my colleagues will have sound memories of that visit there. But we reached the purpose. We went to visit the health center and asked them for a room that we can refurbish to use as a clinical site. So this is the room that we were given with broken windows. It was a sort of warehouse filled with stuff that nobody was using, and we were happy to have a place to work. This is what that facility looks like today. You can see our WANECAM 2 logo there. It's sort of a dedicated clinical research facility with the doctor's office and the lab, the microscopy lab, and then the clinical safety diagnostic lab, and they were very shiny video conferencing facility. So it has fundamentally changed in terms of infrastructure improvement. You can't do trial without vehicles. So the project it provided one pickup truck for them, and these are some of the equipments that are needed for hematology and biochemistry toxicity. And so all of this is done in a coaching context, where to buy the equipment, how to get it through customs, how to install them, how to train the personnel that's going to work on that. All of this is done in a coaching context with the Malian team and our colleague from Burkina Faso pitching in as we move forward. We brought two biologists from Niger to Mali to spend like 3 months working with our teams to get in-depth hands-on training. We had 3 technicians to be trained on RedCap for data entry and data management, and we registered 1 PhD and 1 MSc to have long-term degree training. And the leadership visited our sites in Mali as well as in Burkina Faso to see how we work, how we manage the team, how we manage the funds, how we manage the study, sharing our experience with them. And so we did 2 studies. The first was the randomized trial that I was talking about, and the second was a study to establish biological norms. Actually, we don't have local norms for the various parameters that we will be measuring. So the in vivo study recruited up to 240 patients that were followed successfully, and the norm study recruited up to more than 1,000 people to assess their various biological parameters. So this is the profile of the study. All the study is done by the Niger teams in Niamey, in the health center that we built. At the beginning, we sent 3 staff from Mali. After they came to train in Mali, they went back, and we accompanied them with our staff to spend 2 or 3 months with them to actually coach them while they are recruiting the patients and going through the ethics approval, regulatory approval. All of this is done hand in hand so that they learn while doing. So this is the profile of the study. It's the first results of this study that came out. Again, a learning mode. Learning. It has been very difficult because when we did the QC, after the microscopy, when we started with 10% QC. When we did the 10% QC, the results were not good. So we had to bring the team to Mali again to read all of the slides. And then, again, entering the data entry was problems as well. Again, so it really took a lot of time to get them to the level where they can do this simple study well and prepare them for the phase 3 trial. But we are happy to see that it went well, and they were able to get these results where we can say pretty much 100% PCR corrected efficacy with AL and artesunate pyronidine, and they found that there was higher parasite clearance rate with artesunate pyronidine compared to artemether lumefantrine. This is not for you to read, but it's basically to say that we are able to set lower limit of normal range and upper limit of normal range in the various parameters, the biochemistry parameters. Just look at that liver safety, kidney safety that you can see. So these are the norms that will be used in the phase 3 trial that will start next year. This is hematology parameters. Again, the normal ranges for, and so these are all data generated using the team, using the newly acquired equipment, and using coaching from the larger network. So in conclusion, we have a new team and a new infrastructure that has been developed in Niger through South-South collaboration. It was the one all done by Malian technicians, Malian scientists, and scientists from Burkina helping Niger scientists through South-South collaboration. And they are ready to go into phase 3. There again, we are working with them to go through the more complex regulatory pathway for a trial that will provide data for registration of a new product. Is different from a clinical study that you're comparing already approved drugs. So yeah, with the Novartis team that is coming in now, we are working with them to get them through the regulatory path for protocol approval, regulatory authorization, IP importations. All these stages are ongoing now, and we are confident that they will be ready to contribute the phase 3 trial, the Kaluma trial, then using the normal ranges that have been provided. I'll finish by thanking the lead team there, Prof. Adeusi. It's all start by one good person to build the team around, and Prof. Adeusi has really lived up. In the meantime, he has been appointed as the director of the Niger hospital, and the person who signed the agreement is now the Minister of Higher Education in Niger. So we are in good hands in the country to continue this work. And to thank the government of Niger has been very welcoming whenever we visited there. The Wanakam Work Package 1 and Work Package 4, who has been instrumental in delivering this training, and my junior colleagues, Dr. Fofana, Prof. Sagara, and Prof. Diko, who helped me push these slides together. Thank you for your attention.
Thank you, Abdoulaye. So You know that you're the star of EDCTP. You
Oh,
are
yeah?
our Mbappe,
I didn't know
or
that.
our yeah. But the story about Abdullah is that he got an re-entry grant as a fellow from EDCTP, and since he came back from US, we have never released him. Before he goes, we give him another grant. And you can see his great work in West Africa that has borne a lot of fruits. There may be a burning question before we go on, because time is against us now. Oh my
I have the
goodness.
mic.
Yeah, please.
Hello.
Yeah, you can go ahead, please. Who has the mic?
Thank you, Professor. And I really want to congratulate you for this work that you really do, and sometimes in very difficult and extreme conditions. It makes us African proud. Thank you so much. I believe that when you train these people, if they embrace the quality approach of clinical trials, even long after the trial is gone, they receive some benefit in terms of the quality of care they will give to patients. Now, my question is specifically, I saw that you also set up a lab, whether there have been a formal process to certify or accredit these labs locally, or if that is still pending. Thank you.
Well, we haven't reached that level yet, but we have, like I was alluding to, we have external quality control that is done from within the network. We have a CLIA certified lab in Bamako, and they are the ones doing the microscopy training, and they are the ones doing the quality control. So we have built-in external quality control, and that was during the simple clinical study. Now, moving into the phase 3 study, Novartis, the sponsor, has its own QC microscopy validation and training and retraining system that keeps the team up to speed in terms of quality of the data that comes out of it.
Thank you very much. And I think you undersell yourself, because you make it look easy, and actually setting up Kalumi and Kaluma is very tough. So
yes.
Well done. Just one thing. I think you only get 4% of EMA inspections on the continent at the moment. And we set up for praziquantel formulation that is now being approved. We actually, I think there's a lot of learning between the different countries, and in this particular case, Ivory Coast and Kenya. And I think what would be really helpful, and I'm glad you started that and you're showcasing this, is to actually do the lessons learned from the other countries. Because one of the things that, and I don't know if other people in this room share, with the new regulations coming, we ICH-GCP R3, there are things that are actually is going to be very, very difficult for institutions, especially academic institutions who are supporting all of this also, to be able to meet. And there's a big disparity on experience with the EMA, is that there's a big disparity between what is understood by the policymakers, what is needed from a pharmaceutical company, and then also on the ground, what is actually possible and feasible, and what's actually good work. And so I think it'd be really nice, actually, if it's possible, to start creating a lot more lessons learned from that. But thank you.
Thank you very much. Well noted.
Thank you, and congratulations for the presentation. I am Ezequiel Bartomeu Silva from Guinea-Bissau. My question is a more down reflection. Do you reflect about how to bring another Africa country, especially I'm talking to the Portuguese-speaking country, to this special training? If you see, we have a few money, and we have many problems, and our problem is the same. I can say that the Senegal is the neighbor from Guinea-Bissau. So Senegal be very strong and safe. Guinea-Bissau needs also to be safe, because we have the same problem, the same culture. That's why I think it's very important to start thinking how to bring another country, how to bring them to just once in this training. We are thinking how to make like a Cabo Verde or Guinea-Bissau to be a part of this team, to know something about the clinical trial and to help Guinea-Bissau also. Do you think about that?
Yeah, Thank you very much. We are very much in line with what you are saying. And in another network that we are working with, the Pathogen Genomic Diversity Network Africa, we do work with Lusophone countries. We have collaborators, actually members of the network in Cabo Verde. Silvania Leal is our representative there. In Angola, Joanna Morris is our representative there. And in Mozambique, Pedro Aid is our representative there. So we are in bringing the Lusophone countries as well. Not easy, but trying very hard.
Thanks. As a Malawian, I also know the language barrier between us and Mozambique very well. So, yeah, please.
Thank you for that presentation. I don't know how you do it, but I know that the Science for Africa Foundation in Nairobi also considers you a star for them, funded by them. So I just want to acknowledge that as a representative of Welcome, which co-funds the program that you run, which SFA administers, we co-fund with the FCDO in London. So we're a global funder working with a UK funder. I guess I'd be interested to know how you do it, how you choose which funders to seek funding from, how you balance. You can clearly pick and choose.
Well, thank you very much. Again, thanks to Welcome and to DFID, now it's called FCDO, I heard, for support through the Deltas initiative to our programs. Actually, you know, we have a lot of problems, and we seek for solutions where we can find help. So in the clinical trial field, that's EDCTP, and with Science for Africa, we actually do a lot of capacity building. My program, DELGEM program, does training in bioinformatics and genetics through that master's and PhD training. And actually the second phase is where we are doing this AMR work, where we will be starting a master's degree in AMR. So, and yeah, so depending on where the various needs we have, we seek for support. Where we have not been so successful is really getting domestic funding to pitch in as effectively as we would like to.
Thank you very much, Prof, for that inspirational story. I just want to find out, when you are having these cross-country collaborations, how much of an issue is it, an issue at all, to have data sharing and data management agreements, and how do you navigate this? Thank you.
Yeah, well, that's a very important point. I mean, creating a network starts with building trust between colleagues. And once you build this trust, and you actually reach out to people that you can work with, that trust-building stage comes before the science. For example, our PDNA network, we started with no money, with a few meetings that the late Prof. Dominic funded with, and got to know each other. I have two of my colleagues here. Prof. Marielle from Gabon is here. Umu from KCCR is here from this PDNA network. We learn to trust each other, and then we do science, and then sharing the rest becomes just easy.
All right. A quick question. Thank you for the work. I'm really inspired about it. The question is, are you training research officers that can do the paperwork? Because usually in Africa, the scientists take on the paperwork and the regulations. And I'm also happy that the signing of the grant is now a minister, because having to liaise with the government usually kill a lot of clinical trials. So are you planning that for Ninja so that they can be self-sufficient to be able to go through that in case the funding ends? Thank you.
Yeah, thank you very much. Yeah, at the beginning, like Tom was saying, at the beginning when we were starting as EDCTP fellows, I used to do everything. Yeah,
like many of my colleagues will relate to, you don't have legal support, you have very little financial support, but so when you live through that and you reach a certain level, then you reach funding where you can hire your support team. And right now, with we have a team of managers, M&E officers, communications officers that help in pushing all this and managing this. I couldn't do it by myself. I'm just a manager.
Oh, really? Thanks very much, Abdullah.
Okay.
A big hand to Abdullah. Thanks very much. I must apologize for all of you online. We hear there was a technical hitch. You couldn't hear the first 3 presentations, but your questions have been answered in one way or another, so sorry about that. And now we go to the next presenter, who is Jonathan Wilbank from ERINA in Belgium, Advancing Research on Epidemic-Prone Pathogens, Integrated Services for Infectious Diseases Outbreak. The floor is yours. Thanks. Are you able to do it in 20 minutes?
Oh, absolutely. Yeah.
Okay, thank you.
So first of all, thank you very much to the organizers for giving me the possibility to talk about this project, especially since it's not an EDCTP project, but I hope it'll be of interest to many of you. I think the one thing I'd like to say at the start as well is that within the coordination team of Isidore, the project I'm going to be talking about with my colleagues Audrey Richard and Claire Conlon, we often say that it's challenging. And these last couple of days here have really been a very necessary reminder that the challenges that we have are the challenges of a spoiled child. So I've been very much inspired by hearing all of the work that's been done on the African continent. So I guess I start this up. Okay, so Isidore is coordinated by ERINHA. So ERINHA is a European research infrastructure. So it coordinates the activities of its members, so the members who are running high containment and maximum containment facilities. So we federate the majority of BSL-4 labs in Europe. And the members are listed here on the right. So what we're aiming to do is to provide access to these high containment and maximum containment facilities to researchers who need to have them. And one of the ideas is that by bringing them together, we can allow researchers or research consortia to conduct projects that a single lab would not be able to take on. So we have our missions are defined. So it's the study of high consequence pathogens. So we're looking both at the virulence of the infectious agents, but also at host defenses, doing preclinical research, diagnostics, medical countermeasures such as antiviral drug discovery, vaccines, and really are there to serve the scientific community. ERINA itself has got a list of priority pathogens. They're shown here. Most of them will be familiar to you. And I just say that these are, as you know, pathogens that are, in many cases, endemic on the African continent. And despite the fact that these represent severe health problems on the African continent, within Africa, there are very limited resources for high containment work. And we'll come back to that again at the end. So ERINA gives access to its facilities either in a contract basis. So, for example, we've supported a vaccine development for Nipah virus through funding from CEPI and now from SCADA, or through EU-funded transnational access programs. And I'll come back to that in a moment. And we also provide access to consortia that will be funded, since we're in Europe, principally by the European Union or through, for example, the European Defence Fund. So Isidore is one of these programs that's funded by Europe. So it's under the umbrella of HERA. You heard about HERA yesterday, the Health Emergency Preparedness and Response Agency. So it's a project that brings together ERINHA with a wide range of other European research infrastructures. And so we have 153 partners in 32 countries, offering a wide palette of services that should be of use to the scientific community. And so, unlike traditional funding mechanisms where it's the consortium or the principal investigator who gets funding, in this model of European funding called TNA, Transnational Access, the money goes to the research infrastructure, which is then able to offer free of charge services to the research community. And so in the case of this project, Isidore, we're offering services from the most basic structural biology, bioinformatics, through in vivo models in high containment facilities, to support for vaccine development, regulatory advice, and also with the inclusion of social sciences and epidemiology. And so we've had 2 calls that have now closed. So this was an emergency action of the European community. So it started in 2022. And the first one was for SARS-CoV-2. And then, unexpectedly, there was the Mpox outbreak that spread globally. Here was an example where we were able to demonstrate that this particular type of funding instrument is actually reactive. So we put out a call for propositions 2 weeks before the WHO identified monkeypox as a public health emergency of international concern. And already the results are coming through. So this is just 2 examples in the field of SARS-CoV-2. One of the teams that had benefited from support through this project was able to identify broadly neutralizing antibodies against SARS-CoV-2, and in the other case there was the design of an inhibitor of a viral protein. Currently we've got 4 calls that are open, so they're listed here. Risk group 4 pathogens, vector-borne pathogens, respiratory pathogens, and pathogen X. And you can find details of that on the Isidore website. So just to give you an idea of what has been funded, so since the earlier calls were focused on SARS-CoV-2, most of those projects that have been funded do correspond to SARS-CoV-2. One thing that's important to point out is that 75% of applications have been funded. So this is unlike most funding programs. And one of the reasons for this is that if you do apply for funding, you're helped during the application process by the research infrastructures to make sure that your application aligns with the capacities and what's available. And then on the right, you can see which countries have benefited from funding from this program. And I've just highlighted the countries in Africa. So for example, Cameroon has had 3 projects, South Africa has had 2 projects funded. And on the next slide, I also give examples of the programs within Africa that have been funded. In the social sciences, a study looking at, as far as health workers are concerned, what are the factors that could influence their vulnerability to infection by dengue and malaria. A project that's trying to develop a vaccine based on the antigenicity of mosquito salival proteins, genotyping of mosquitoes looking for insecticide resistance, and an attempt to identify a target for multi-drug resistance TB. So just finish on another project that Arena is coordinating. This is called Interceptor. So currently, the activity of Arena is focused on Europe. There are high containment facilities, BSL-4 labs, in other countries. There is a need for global coordination, and Europe has funded us for 3 years to try and start this type of global network involving partners in the US, in South Africa, in Australia as well. And we hope that this will be a mechanism that expands, as I said, the network. So we want to give to researchers worldwide who need to have access to high containment facilities the possibility of doing that by brokering this access. Clearly, you will all be aware of the debate that's going on at the moment about the risks involved in working with high consequence pathogens, and this project is going to be a forum for dealing with some of those issues, promoting harmonization of practices and knowledge, and hoping that we will then become a more efficient instrument, globally coordinated, to help when research is needed for these pathogens. And that includes, for example, the late steps in preclinical development, where you need to have in vivo tests with live pathogens if you're going to develop a viable vaccine candidate. And lastly, demonstrating that this research is essential if the world is going to be better prepared for future pandemics. And I'll finish there and be happy to answer any questions. I'd just like to point out that at the back of the room, standing up, there is Claudia, who's a colleague from ARENA. So if I'm not able to answer the questions now, Claudia will be around. And I also think I saw William, who's from the EVI, William at the back there. So he's from the EVI, who's another Isidore partner. So that's the European Vaccine Initiative, if you have questions about what their service offer in the context of Isidore is.
Thank you very much. I think it's a very inspiring example of how to reach better coordination and efficiency of funding, and I think the success rate is mind-blowing. So feel free to apply. I think it's it's a good incentive. So any questions for Claudia or Dr. Eubank?
Everybody wants to go for lunch.
That's an issue here, the issue of awareness, because I think for me, really, getting aware of this for the first time. So maybe also most people, like your applications, how can people access this and just to be visible, really, so particularly for African countries.
Right. So first of all, I should say, in common with most EU-funded programs of this nature, 20% of the funding is available to researchers outside Europe. We've been trying to promote this. So we had a ARENA Africa workshop, which was attended, for example, by representatives of the African CDC. And we've also, we sponsored recently the inaugural meeting of the African CCHF conference, which was held in Cape Town not very long ago, where we were able then to reach out to those researchers. I mentioned that CCHF is one of the priority pathogens. So again, through a separate EU-funded program, we're moving forward in vaccine development for CCHF. Just parenthetically on that, since people were talking about One Health earlier, so this is a very interesting example, CCHF. So in a certain sense, it would be a perfect One Health pathogen, apart from the fact that it causes no disease in animals. So it's prevalent within the wild stock across the African continent, but vets don't care about it because it doesn't cause sickness. So you can't encourage that mutual funding support that you should have for that type of program unless people take a much broader perspective on what One Health actually means.
Are you also on social media, please? LinkedIn?
Yes, there's a Twitter account. Yeah.
Thank you.
Thank you very much, Professor, for that insightful presentation. I'm just curious, at least to get your perspective, because I think based on what you present, I think we see that European researchers and leaders in global health are really successful in setting up initiatives, particularly funding initiatives. Are there any lessons that we can learn, particularly be from Africa, or is there any support that you guys can provide to enable African researchers use similar mechanisms or approaches to set up such funding bodies within the African continent? I know there is a African CDC, there is a AU, and there are so many African organizations. Are there some practical approaches that African leaders like Professor Jimde can use to establish similar platforms for the African continent?
So I think that in part needs to be a discussion with the funders. And if there is to be a discussion with the funders, when there are initiatives of this type, frequently there's an initial heavy investment, but no long-term continuity. And I think that whenever funders think about setting up any initiative of this type, there is a need right from the outset to see, well, if this proves to be something that is working and is responding to a need of the research community, how are we going to continue? And it shouldn't be a second thought. At least in Europe, the research landscape is littered with good projects that had an initial investment, but then were allowed just to wither and die. So there's this constant recreation, reinventing the wheel at the expense of things that have had initial investments and could have been successfully expanded or adapted. But so that.
Thank you very much. A very quick final question before we move to the last session.
Yeah, thank you. These high containment labs, I think they are quite infrequent in Africa. Say, for example, I may be wrong, but the BSL-4, I think there are 2 in Africa. One is functional, and one may not be quite functional, the one in Gabon. The one that's more functional is the one in South Africa. There are limited number of BSL-3, especially in West Africa. But the point here is that these highly infectious pathogens, Lassa, Ebola, most of the countries that are impacted by these highly infected pathogens, predominantly most of them do not have these high containment labs. So these samples are shipped to countries that don't have ownership for these samples. So the question to you then is, how is the ethical approval process work? I mean, you're providing funding, but it's important to know what is the governing structure for these samples that are being held in this lab that don't belong to them, because the country where the sample originates from is the owner of the sample technically. So what is the ethical procedure? Are you just administering funds, or are you ensuring that these steps are adequately guided to ensure that ethical procedure, regulatory procedures, ownership are all appropriately addressed before you provide funding for these kind of collaboration? Thank you.
Absolutely, and that's an important issue. So we work in the context of Isidore with the European Virus Archive, and they have a dedicated section of their work to ensure compliance to Nagoya Protocol. And so this is the principal mechanism that we use to ensure that. We are also now teaming up with the European Virus Archive, with the European Bioinformatics research infrastructure that's called Elixir, and we've been funded by the EU for a program that's called Evora, which is the European Virus Outbreak Research Alliance. And within that, the idea is that the Virus Archive, which is a distributed network of virology labs, including labs in Africa, have the biological resources. ARENA has the physical containment capacity, and Elixir has the bioinformatics support to allow an integrated approach. And within that, there is precisely a work package to try and come up with, in fact, potentially even more equitable solutions, but more important, solutions that allow rapid transport of materials. Because if there is an outbreak, and if there isn't a capacity within that country, you need to get those samples out. And it doesn't make any sense for global health that those samples should not be transportable because of barriers that could be overcome.
Thank you very much. We can give a round of applause to Dr. Again. And to finish this session, we're very happy to now show the video, which is now available. And we will then have Professor Olupo, who will be joining us online for any questions. So we can launch the video. Thank you.
Capacity building as a response to emerging and re-emerging infectious diseases in Africa is my presentation today. In this presentation, I will cover areas on capacity building that have been initiated by the EDCTP supported IDEA Fellowship Program. My name is Professor Peter Olupot. I'm the coordinator of this grant, and I work with Busitama University and the coordinator of this grant. So briefly, I would like to let you know about the scope of this presentation, and we shall cover the capacity building gap, the vision and the mission, background and the collaborations that have brought this grant together, and then showcasing the IDEA Fellowship Program that is building capacity to respond to emerging and re-emerging infectious diseases in Africa. As I have already alluded to, the first part of our discussion is the capacity gap in sub-Saharan Africa. And here we notice that there is inadequate response to emerging and re-emerging infectious diseases, as evidenced by a long lapse between the outbreak and the recognition. On average, it takes 3 weeks for the outbreak to be reported. The current field epidemiology training programs are non-degree awarding. And so it's not attractive to many of the people who would be interested in pursuing a career in field epidemiology. In all the reports that we have received from the WHO, the World Health Organization International Health Regulation Standards has highlighted the lack of the requisite capacity to respond to emerging and re-emerging infectious diseases. And most of the efforts in sub-Saharan Africa are fragmented. So the IDEA Fellowship Program derives its mandate from its vision of strengthening capacity building in infectious disease field epidemiology through a pragmatic fellowship training program. And this vision is shared by all the consortium members, and so it was easy to come together to address the problem of capacity building in sub-Saharan Africa. So this slide shows us the background. It started way back in the year 2006. And from that year up now, we've done a lot of things to put this in place. For instance, we decided to set up the research and the training systems in the year 2006 to 2013. By 2011, we had involved Uganda, Kenya, and Tanzania in clinical trials capacity. By 2013, we recognized that the way to go was to do surveillance that would enable recognition of disease outbreaks and epidemics. By 2014, we invested in some pathophysiological work to understand the disease effects in the body and the systems. And then in 2014, we embarked on training a critical mass of people who would now steer this type of grant in our region. So people were trained in Master of Public Health, PhD, and research methods. And by 2015, we embarked on infrastructure, equipment, and networking. So by 2020, we developed a curriculum that we are now using for the training in infectious disease field epidemiology. By 2021 update, we are embarking on training and research as a means of capacity building for responding to emerging and re-emerging infectious diseases in sub-Saharan Africa. So this is possible through strategic collaborations with the Uganda National Public Health Institute, Uganda National Health Laboratory and Diagnostic Services, Uganda Virus Research Institute, Mbale Clinical Research Institute, Infectious Disease Institute, Ministry of Science, Technology and Innovation, and the Open University. This slide is busy and has a small font, but briefly, this is how we have divided the work packages for each institution and feeding into the overall proper coordination of the program. We have also set up the IDEA Fellowship Consortium Secretariat that manages the grant at administrative level. Talking about infrastructure, equipment, and staffing, each of the consortium members has this. This is just a demonstration of these three aspects at Mbale Clinical Research Institute, but all other institutions have similar setup. And so the collaborating institutions come with infrastructure, equipment, and staffing that are needed for the training program. Just to look at the IDEA Fellowship Program, the main goal is to equip the epidemiology fellows with knowledge, skills, and competences. Competences there has been highlighted because at the end of it, it's the competences to respond to emerging and re-emerging infectious diseases that we are looking for. And we are building leadership capacity in infectious disease surveillance, disease outbreak investigations, infectious disease outbreak response in all of this. So we have got an approved curriculum. You can look at it on your left, and on your right is a picture of the first cohort of the epidemiology fellows that are under training. And these are the fellows who are profiled again individually. So the program requirements and regulations are that this program has a duration of 2 years of 4 semesters. Each semester is 17 weeks. And we attract early to mid-level career fellows who already hold a master's in a health-related field. And we initially admitted the first cohort of 15 fellows, but we have 13 who are currently progressing very well. This program will lead to an award of Master of Science in Infectious Disease Epidemiology of Busitama University. The justification for this program includes that this is a Master of Science in Infectious Disease Field Epidemiology, and it has been informed by the research gaps and the capacity gaps in Sub-Saharan Africa. No program currently trains specialists in this area, so this will be the first to train specialists in Uganda, and these fellows will also be available to work in any other part of Sub-Saharan Africa. There was need for local capacity as indicated by the WHO standards regulation. And then we would like to harmonize training for the national and regional interests, and so establishing a career path in infectious disease field epidemiology in Uganda and Sub-Saharan Africa. The program competencies have been put into 4, but under each of these 4, there are sub-themes. Particularly, the competencies encompass infectious disease outbreak surveillance and reporting, infectious disease field epidemiology, infectious disease biostatistics, infectious disease outbreak response. These competences cover all the 4 areas that are required for recognition, surveillance, monitoring, and response to disease outbreaks. The EpiFellows training has been moving on very well. For the first cohort, we have completed the first 12 months, which covered all the theoretical work. And during the 12 months, we also conducted projects that are listed there. And in the next 12 months, they are doing their field work under the mentorship of field supervisors and the faculty. And then they will also complete their Master of Science research project. On the right, you'll see a picture of Mbale Clinical Research Institute that hosts the Secretariat. We also held the first IDEA conference on emerging and re-emerging infectious diseases on the 13th to 14th of September 2023. It attracted 150 participants, both local and international. The conference was held both physically and online. And the key presentations on emerging and re-emerging infectious diseases were held with the EpiFellows leading on the organization and also some of the presentations. And then we had the participation of key stakeholders, including the World Health Organization, the Ministry of Health, the regional and the local health establishments, and the NGOs. We also had networking, and there are new networks that have emerged out of this conference, all to the interest of strengthening of response to emerging and re-emerging infectious diseases. We have a report that's now available to be shared both with EDCTP and internationally. And there's a promise that the second international conference will be held in the year 2024. We have had some challenges in the implementation of this program. First and foremost, that this is a scholarship level funding. It requires a program level funding that should be able to take care of capacity building in and around Sub-Saharan Africa. The duration of the current project is 3 years, and we are starting to ask ourselves questions, then what? How are we going to sustain this program? We think the solution to this is to have at least another round of funding, preferably at program level. This program has already registered a lot of impact. Firstly, that we now have a nationally recognized curriculum on infectious disease field epidemiology that's training specialists. Secondly, that 13 emerging and re-emerging infectious diseases are being investigated by the AP fellows, and they are writing also policy briefs that we are sharing with the Ministry of Health. We have participated in the development of guidelines on black water fever, which is an emergent condition common in the Eastern Uganda region. We also participate in the Ministry of Health Malaria Scientific Advisory Committee programs, and we do data sharing, including the malaria fora. And networking is part of the impact that we have recognized. In conclusion, the IDEA Fellowship Program is being implemented through an approved curriculum. The first cohort of the AP Fellows have impacted recognition and the control of 13 emerging and the emerging infectious diseases, and the sustainability of these activities requires program level funding. I would like at this juncture to recognize the contribution of EDCTP in providing the grant which is championing this work, and also recognize all of those consortium members represented by those logos. Thank you very much, and I would like to stop my presentation here.
Thank you, Professor Olopot. So there we are, ladies and gentlemen. This is the end of our session. And as you have seen, to conclude, you can see that within the ecosystem, with the systems that we covered here in 3 domains, people, systems, and infrastructures, we have a huge task to make sure that they are all up to scratch to wage the war against the diseases that are affecting us and have a lasting impact. With that, I would like to thank all of you that presented and the audience with the nice questions, and to my co-moderator Lydia as well, and wishing you the best of the rest of the conference. Thank you. Have a nice lunch.